So good evening. My name is Addisu Mesfin. I'm joined by Doctors Emmanuel Menga, Dr. Molinari, and Jarren section, our spine fellow. We're going to be discussing the management options of cervical facet fractures. Again, these are our faculty. Our disclosures are not relevant to this talk. Just FYI, the next AO Spine Fellows webinar will be Surgeon Know Thyself on June 9th, 2020, how to transition into practice and not lose yourself. And these will be some of the webinar topics for the remainder of the 2020. So I'd like to introduce Dr. Robert Molinari. He is our spine division chief, professor of orthopedics and neurosurgery, and a longtime AOS faculty. He'll be starting off the webinar with the didactics on the management of cervical facet fractures. As far as for the participants, if you have questions, use that Q&A box, and we'll be able to address those during the Q&A portion of the talks.
Okay, good evening, everyone. I'm going to share my screen here and pull up my talk. I'm going to start out the symposium tonight with a lecture on cervical facet injuries. Let me see if I can just pull this up. Okay. Okay, so again, it's a pleasure to be speaking with you all tonight. I'm going to talk about cervical facet injuries. And I'm going to start out by talking about the new classification system that the AO has. In 2016, Vaccaro et al. Published a new AO spine cervical classification system. And it's a good classification system. It's in keeping with the traditional AO classifications. The type 1s are compression injuries, or the A's are compression injuries. The B's are extension, or flexion, distraction type injuries. And the C's are rotational injuries. But what's nice about this classification is the AO included this F category, which is a facet injury category, and that's what we're going to speak about tonight. So if you look at this F category, the first is an F1. It's an F1 is a fracture of the facet that's less than 1 centimeter, and it's less than 40% of the lateral mass. And as we all know, those are inherently stable fractures, so that's why it has the modifier F1. F2 is a facet fracture that's greater than 1 centimeter or greater than 40% of the lateral mass, and it does have the potential for some instability. F3 is unique fracture. It's a floating lateral mass, and that's a fracture that encompasses the lateral mass, but also the ipsilateral pedicle, making it highly unstable at 2 levels. F4 is a perched or a dislocated facet, and as we all know, this is the most unstable variety of facet injuries. At the University of Rochester, we still like to use the SLIC classification as described by Vaccaro in 2007. We think this is easy, it's reproducible, and it's a very decent classification system for cervical injuries. It entails describing morphology, discal ligamentous injury, and the neurologic status. So for instance, if we look at this injury right here, which is a unilateral facet dislocation, it gets 4 for morphology because it's a dislocation type injury. It has posterior element injury, so it gets 2 points for the posterior element injury. And we'll say there's a nerve root injury, an ipsilateral nerve root injury, so it gets 1 point for that. And with the SLIC scoring system, it's a 7, and that's greater than 4, so it entails operative management. So again, we think this is simple. It's easy. We like the AO classification system. We do refer to that, but for the majority of our call cases, we like to use the SLIC system. So moving on, if you look at controversies with respect to facet injuries, I think a big one is the initial closed reduction of cervical fracture dislocations. Is it safe? Do you have to do an MRI before? What does the literature say, and what are the prevailing attitudes in 2020? Well, if you look at the literature over a 50-year period, looking at the initial guidelines that were published, guidelines to management of cervical spinal injuries, you can see there are about 42 articles with 1,200 patients who underwent closed reduction. 80% of those patients had restored anatomic alignment. Only 11 patients out of 1,200, which is 0.92%, had new permanent neurologic deficits. And only 2 of those were cord injuries. So for the most part, it's pretty safe to do an awake close reduction. 20 out of the 1,200, 1.7%, had transient deficits. Now, what are the causes of these neurologic injuries? They're over distraction, a non-contiguous or a missed injury, the dreaded disc herniation, hematomas, or spinal cord edema. But as you can see from the majority of the literature, it's pretty safe to do an awake close reduction. Okay, so what else does the literature say about this? Some great articles were published with respect to close reductions. Rizzolo, 1991, 55 patients had a pre-reduction MRI. And what did it show? Over half of them had a herniated disc. They all underwent closed reductions, and there was no complications in any awake or alert person. So again, Rizzolo says it's safe to do these closed reductions in an awake patient. Grant in 1999 did 80 post-reduction MRIs and found that half of the patients had herniated disc. Once again, there was no correlation with clinical outcome. Didn't make a difference with respect to neurologic status. And Vaccaro in 1999 looked at 11 patients in whom he did a pre and a post-reduction MRI. Pre-reduction, only 2 patients had a herniated disc. Post-reductions, 5 did. But guess what? None of them had neurologic deterioration, and the MRI didn't predict neurologic deterioration. The presence of a herniated disc didn't predict neurologic deficit. So what are the take-home recommendations with respect to closed reductions in awake patients? If the closed reduction fails, there's a higher incidence of anatomic obstacles, facet fractures, or the dreaded herniated disc. These are the patients that should have an MRI prior to open reduction. The disc herniation in this setting is a definite indication for the anterior approach and anterior decompression prior to the reduction. And certainly we MRI all patients who can't be examined for neurologic deterioration. So any obtunded patient, any patient comes in that's intoxicated should undergo the MRI before having the closed reduction. Okay, so what about facet dislocations? What about closed management? What do the guidelines say about that? Again, literature over a 50-year period, 28 articles, over 700 patients, 26%, 181 out of 701 patients failed to achieve closed reduction with cranial cervical traction. So in a quarter of the patients, you couldn't reduce them. Reduction, when it happened, when it was accomplished, could not be maintained in another 28%. That's 112 out of 393 patients. So again, either you couldn't reduce them in about a quarter of them, or if you reduced them, they fell apart in the other quarter. That's 50%. There were no differences in the success rates of closed reductions, maintaining alignment with respect to unilateral or bilateral injuries. And if the patient healed with malalignment, it caused them pain. So again, this is pretty dismal with respect to closed management of facet dislocations. All right, so what about operative treatment? Literature looks at the operative treatment and the guidelines, and it says with anterior procedures, there's delayed instability in about 6 of the 100 patients that were analyzed. And with posterior surgery, there's delayed instability in 6 out of 237. So only 3% delayed instability with posterior with respect to anterior. And you'll see why later, why the anterior may have a greater incidence of delayed instability if certain features of the injury are missed. Okay, so what about unilateral facet injuries? What do we know about that? Well, we know that they entail significant injury to the dorsal ligamentous complex. That's been shown in multiple studies. We also know that there are higher success rates in the published literature with surgical management than the non-operative management. That's true. Surgery leads to more consistently better results than non-operative management. And you can see there are multiple studies that show here. Granted, there's a paucity of literature. It's not the best literature out there, but it does give some credibility to the fact that surgery has more consistent results, okay? So with that said, which facet fractures can be treated non-operatively with success? What are the features that we look for? And how did we get there? Halliday's study in 1997 looked at 24 patients with unilateral facet injuries. Granted, it's a retrospective study. 12 were treated surgically, 12 were treated non-operatively. They did an MRI to evaluate the facets, the capsules, the interspinal segment, the ALL and PLL. And what did they find? 9 out of 10 patients who had progressive subluxation in the non-operative group had significant ligamentous injury. 3 to 4 major ligaments were injured. So again, these all have significant ligamentous injury component to them. Spector in 2006 looked at 24 patients who had unilateral facet fractures who were treated non-surgically. 5 of the 24 failed, okay? And this article is the article that gives us these risk factors that are included in the AO classification. So again, it's only 24 patients, paucity of literature, okay? But what does it tell us? It says the risk factors for failure in this study were articular fracture height greater than 1 centimeter, absolute fracture height greater than 1 centimeter, and percent of the lateral mass greater than 40%. So what am I talking about here? Well, here's how you measure articular fracture height. You measure the articular surface, and again, it's got to be greater than 1 centimeter for risk of failure with non-operative treatment. Here's the absolute fracture height. It's a vertical height of the lateral mass, and here is the total height of the articular surface. So again, when you're looking at percentages, you're looking at this over that. And again, if it's 40%, it has a higher risk of failure with non-operative management. But again, when you go back to this study and look at it, we quote this study, or we quote those numbers all the time, but keep in mind, we're really talking about a study that only included 24 patients. Okay, so what about the surgical approach? We're going to talk about that tonight. We're going to show some very interesting cases of facet fractures and fracture dislocations, and we're going to discuss the role of anterior and posterior surgery. I'm going to show you here, this is an example of posterior fixation only, and it's a great treatment for cervical facet dislocations. It really is. It's simple to do. The reductions are pretty easy. You can use a towel clamp. You can drill down the articular surface of the facet, and it's pretty easy to reduce a facet dislocation posteriorly. Again, these ligaments are often disrupted, so it's pretty easy to manipulate the posterior spine intraoperatively, as you can see here. The downside is the posterior approach may involve fusing more than one level. Most of these injuries occur at one level. Anteriorly, they're typically done at one level. Posteriorly, you may need to include an additional level. This is a C7 cervical pedicle screw, and this is a one-level procedure. But if you look at some of the posterior procedures that you'll see tonight, they're multiple level operations. Okay, so what about anterior surgery? Well, Kwan looked at this in 2007. He did a prospective randomized trial of anterior versus posterior stabilization for unilateral facet injuries. And what did he find? There were some trends towards advantages of anterior surgery. Patients had less pain, there were higher union rates, they had better postoperative alignment, and they had lower infection rates. And in addition, he also suggested that the number level fuse was less with anterior surgery. There are many techniques to try to reduce the fracture anteriorly. A dislocated spine is much more difficult to reduce anteriorly than it is posteriorly. I think that's going to be one of the major take-home points of this symposium tonight, that it's much easier to reduce the spine from a posterior vantage point than it is from an anterior. But what I'm going to show you now are some slides that show how to reduce the spine from an anterior approach. And over my 20 years, I can tell you I've struggled with this intraoperatively. There are a couple of cases where I had to abort the anterior procedure and flip the patient over because I couldn't reduce it. But this shows the divergent cast bar pin technique, where you put your cast bar pins in at an angle, okay? You then put your spreader on, you distract, and you uncouple the facet joints, and you're able to reduce the fracture, okay? This shows the use of a laminar spreader to get greater distraction, and pushing back on the cast bar pin as another technique to do an anterior reduction, okay? And these are just some examples intraoperatively of how to do that. This slide is from the AO Basic course. Many of you may have gone to the AO Basic course, but AO Basic course is an excellent forum to learn principles of general spine fracture care. Okay, so Johnson looked at failures of anterior surgery with flexion distraction injuries. And what he found is that there was a 13% failure rate in the ACDF surgery with 87 facet fracture dislocations. Again, these are highly unstable injuries, and the risk factors he had for failure were end plate fracture. It is not a good idea to do just an ACDF for a facet fracture dislocation that has an end plate fracture or a fracture of the vertebral body. Again, highly unstable, and you're asking a lot of your anterior column support to hold just an anterior procedure. Over distraction is another common rookie mistake for failure of anterior fixation alone for facet injuries. As I said before, these ligaments are typically destroyed. It's easy to get in and distract with your cast bar. And if you equate this to a degenerative case where you're trying to get maximum distraction and open up those neuroforamina, the concept doesn't apply here. You can easily over-distract these. If you're putting in a 10, 11, 12 graft, you've definitely over-distracted. When you do an ACDF for a facet fracture, the graft should be typically undersized, 6, 7, maximal 8. If you're putting in more than 8, you're at risk for over-distraction. And then lastly, the facet fractures. If you have fractures of both facets, the posterior restraint hooks are gone, and those are risk factors for failure of anterior surgery alone. This is a case of Rick Branchford. It's not his case. It was sent to Harborview Medical Center after it was done, but it's a classic example of a patient who had a facet dislocation injury, who had an end plate injury, which you don't see here on initial CT, but it was there, and you can see it here in the fixation, and was sent to Rick Branchford at Harborview after it failed, but you could see it failed right through the end plate fracture. And Rick had to revise this anteriorly and posteriorly with surgery. So again, not a good idea to do just ACDF surgery for facet injuries that have end plate fractures. Okay, so what about just considering the posterior approach? Posterior approach is great. As I said before, it's easy to reduce. Certainly if they're associated vertebral body or end plate fractures, it's the way to go. If it's a rigid ankylosed spine, it's definitely the way to go. If there's osteoporosis, I would agree the posterior approach is with a longer construct is probably the best procedure. So, and in cases where they're at the cervical thoracic junction, it's certainly easier to approach that from posterior vantage point than as an anterior vantage point. We, in 2009 at the University of Rochester, published a series of 19 patients who were treated with ACDS with allograft and a plate for unstable posterior injuries. When we look back at this study, pretty interesting that a surgical time average, the quick case is only about an hour for a surgical time. The blood loss is minimal, about 50 millimeters, and the length of stay for 13 patients was only about 2 days. Outcome scores were pretty good. We didn't have any significant failures. Again, we didn't over distract. We didn't include end plate fractures with this, and we just showed that you could use an allograft and an anterior plate for posterior injuries with success. It's been shown multiple times after this. Another point I want to make tonight is that it's very rare to see these in kids. We did publish a facet dislocation, a unilateral facet dislocation in a 9-year-old boy. Not much is written on this. I certainly would hesitate to fuse a 9-year-old boy if I didn't have to. And in this case, as you can see in the slides, I did not have to do that. This is a 9-year-old boy who was wrestling with his brother, was thrown on his head, and you can see he presents with a step off at C4 5 to the emergency room with neck pain. He had flexion extensions fused done in an outside facility that show that he has some anterior soft tissue swelling. He does have the step off, but he was misdiagnosed. He was sent out after the flexion extension views. He came back a couple of days later with significant pain. He presented to our facility where we did a CT scan, and you can see the unilateral facet injury that he has here. Again, 9-year-old child, still developing. We did an MRI on him. There is no disc herniation. You could see the capsular injury and the facet dislocation here, okay? So what I elected to do with him was to take him to the operating room. I did not want to do an awake close reduction in a 9-year-old. It's pretty traumatic. I think we're limited in the pediatric population with our ability to do awake close reductions. So again, I got the MRI in him. I showed that there was no disc herniation. I took him to the operating room, and under maximum neuromonitoring, MEPs and SSCPs, I did a close reduction under general anesthesia. And then here's a reduction, okay? And then here are the oblique views showing that the reduction is maintained. And I put him in a collar. I left him in a collar for 10 weeks. And I took him out at 10 weeks, and here's his 2-year follow-up. He healed. And this is an example of a unilateral facet dislocation in a kid, which was treated non-operatively with success, okay? Another injury which I'd like to point out that's highly unstable is the floating lateral mass injury. It's a variant. It's the F3 variant in the AO classification. And what's different about this injury, it has a fracture through the facet, so the whole lateral mass becomes unstable. It's a superior and inferior facet, and it's actually a two-level injury. You can see that. You can see that right here. You can see here's the floating lateral mass on the AP. And here is the classic characteristic CT scan that shows a fracture through the pedicle and the fracture through the lateral mass. Here's an MRI, it shows no significant disc herniation, but there is a little hematoma here at the level of the injury. Okay, it's a two-level injury treated successfully with an ACDF. So please, you have to look at the facet joints, you have to look at the lateral mass, and you have to look at the pedicles for every injury. In general, fractures that fail non-operative management, from my 30 years of experience, are fractures with 40% vertebral compression, fractures with greater degrees of kyphosis, 15 degrees, and fractures with significant subluxation. They tend to do poorly with non-operative management. The last point I want to bring up in my talk tonight, and the point that very few people talk about when it comes to closed reduction of these injuries, is the patient who comes in with pre-existing severe spinal stenosis. This is a recent patient of mine who came in with a facet fracture dislocation injury. You can see that C7T1. You can see the injury here, okay? But when you look at the CT scan, there's severe stenosis at C5, C6. And again, I've just become very, very anxious about pulling significant amount of traction on these patients who are very tightly stenotic. I had a patient recently who developed a worsening neurologic deficit because of stenosis above. And I think you can cause problems with traction. So while we do advocate await closed reductions in everyone, I think you have to be very careful on people who have tight stenosis. And certainly if they start to mention that they have any tingling, or if they show any signs of weakness, let off the traction and be aware of underlying spinal stenosis. So in summary, facet dislocations, but typically ones with neurologic deficit, should be reduced as quickly as possible. Okay? Closed reduction is an excellent way of doing that. Okay, await closed reduction. The need for MRI before closed reduction is not clearly supported in the literature, as I showed you with the 50 years of articles from the initial guidelines. MRI is recommended, okay, if there's a large disc herniation present, and or if the patient is obtunded and there's a neurologic deficit present, okay? There are many options to treat these, anterior, posterior, as you're going to see in the ensuing cases that we're going to show you. I become more enamored with the posterior approach lately, but you know, as we've published and as you're going to see tonight, the anterior approach works very well. Okay, thank you.
So thank you, Dr. Molinari. That's an excellent overview. So we'll open up for questions. You can use that QA tab in the bottom. We'll have about 3 minutes for Q&A. So this is for you, Dr. Molinari. It says, how close do you follow the pediatric patients with the closed reduction? Do you do weekly images? Do you follow them every other week?
So Addisu, with that patient that I showed you, we followed the patient every week for the first 4 weeks. Again, you know, not much is published on facet dislocations in the very young population. And if you're going to treat them non-operatively, you have to be very diligent in following them. So we did it every week. We admitted the patient after the closed reduction. So we got a series of x-rays in a couple of days. And then we did it every week for the first 4 weeks, and then every few weeks after that. But we kept the collar on about 10 weeks or so, and you were very diligent following the patient.
Okay, this is from Dr. Owner Kara. He says, is there any role for the rotobed treatment in patients with three injuries?
Hello, Dr. Kara. Hello. You know, so Dr. Kara last, when he was a fellow, we did use the rotobed. You know that, Addisu. We did use it here. The rotobed for patients with ankylosing spondylitis, or patients with non-contiguous injuries, or patients who are just too sick to have an operation. We do have experience at the University of Rochester with that. And you've seen that too. So I'd say in a very select few patients who have multiple injuries or major comorbidities who can't tolerate surgery. But as you can see from the paper we published, some of these surgeries are less than 60 minutes. So If you can do the operation safely from an anterior approach, I think it's wise to do it from an anterior approach.
So we'll take one more question. This is from Michael Gassibi. He's asking, how do you assess anterior base size of graft with bilateral facet dislocation?
Very difficult to do. So what I do is I look at the adjacent discs on the CT scan or on the x-ray. So you know the size of the adjacent disc, which should be normal. But again, it is very easy to over-distract. I cannot remember the last time I did a bilateral facet dislocation and I put in a larger than size 8 graft. Usually my go-to graft is a 7 or even a 6 with this. Again, you're not trying to distract here. All you're trying to do is reduce the spine and weld it together with a graft and a plate. I think, you know, anything over, you start putting 9, 10, 11 grafts in, I think you're asking for trouble. I've had some failures with over distraction early in my career.
Right. Just to stay on time, there's one more question. We'll address that during the next case. So Dr. Menga is going to move it ahead with some case discussions and case presentations.
Where's my slide here? Hello, everyone, and thanks for attending the webinar. And thanks, Dr. Molinari, for the great talk. I have 2 case presentations for patients presenting with facet fractures and one with unilateral perched facet and facet partial dislocation. So these are my disclosures, nothing pertinent to this talk. So first patient is 69-year-old male. He fell off a flatbed truck while at work in West Virginia. He was actually able, so he fell about 12 feet onto his back, had some back pain and neck pain, but he actually got into his 18-wheeler and drove it back to upstate New York. And 3 days later, due to his persistent pain, he presented to the outside hospital. And I was contacted by the outside hospital. We cover a few hospitals around the area. So they were contacted about getting the patient transferred after the CT scan was obtained. He reported pain radiating down his arms intermittently. He had been able to ambulate with minimal issues and endorses some minor weakness and imbalance with his gait. Past medical history, BPH, CHF, AFib, rheumatoid arthritis, emphysema. Due to his BPH, he had some difficulty with urinary production, which he said was worse since the accident. On physical exam, he had a positive Hoffman's bilaterally, 4 out of 5 tricep strength, 4 out of 5 left wrist flexion and extension and finger flexion. So certainly had some neurologic symptoms. So this is CAT scan. Let me get this out of my way here. So this is CAT scan that was performed after, at the outside hospital before he was transferred to us. So as you can see from the CAT scan, this is starting on the right side. And you see significant facet, so it's not completely dislocated, but it subluxed anteriorly on the right side. It's at the C4-5 level. You see, because of the subluxation, the anatomy is tough to, because it's not the same. You know, when you look at the axial view, it's not the same cut as the sagittal. So as far as the alignment, so it doesn't give you a great view of the spinal canal, or the axis of the axial view is not completely correlated with the sagittal, so hence the film. And you see the coronal view, he has severe multi-level spondylosis. So moving on to just, so these are like the key sections. So now there's a midline of the spine. So you see he has this flexion deformity, chronic spondylosis. So you know some of this deformity is likely chronic and not all related to the trauma. So at 3-4, he had anterior subluxation, which could be and suspected to be likely chronic. So the main injury was an injury at C4-5 with less than 50% anteriolisthesis, severe spondylosis at 5-6 and 6-7, and even also at 7-1. Next section is all the way to the left side, and this is going towards the facet. So you see almost near complete dislocation. There's not completely dislocated, but there's some certainly subluxation. on the left side, so bilaterally. So this is the MRI, one of the key images for the MRI. So see 2, 3 MRI. Think about it with the CAT scan. It's done. You know, typically you can get a CAT scan within 5 minutes. MRI, the patient is laying there on the table for over 45 minutes. So you know they lose some of their guard against pain and just settle there. I mean, you know, some of you have had an MRI, you sometimes fall asleep during the MRI. So you can, as suspected, I think the C3-4 was chronic, C4-5 is the injury, and then severe spondylosis at the adjacent segments below. And based on this, so you see the central canal, and you see severe stenosis here on the axial view and some foraminal stenosis, severe on the left and severe on the right at 4-5. This is 5-6. He has severe bilateral neuroforaminal stenosis at that level. And at 6-7, so, and you know, again, this is chronic. So in the trauma setting, sometimes you have to be able to, you know, talk to the patient, get an exam, and try to determine what is chronic or acute, and make a decision, especially if there's an emergent treatment, make a decision whether or not you're trying to address chronic issues which may be asymptomatic versus addressing the fracture and what is symptomatic at the time. So this at 5-6 had severe stenosis on the right side and also on the left side on the foramen. And at 6-7, also had severe stenosis there. So the question then, do you go ahead and address all of his pathology, or are you really just trying to stabilize his spine? Because prior to this injury, he had absolutely no, very minimal neck pain, no radicular symptoms, reported no concern for myelopathy. So are we trying to treat a degenerative process problem during an acute setting for trauma, or do you want to address strictly the fracture? So the first question here is, how would you manage this patient? Would you do an anterior approach, a posterior approach, anterior and posterior, or would you treat him non-operatively? Are we able to see the results from the? All right, so 32% said they will manage it anteriorly, 32% posteriorly, so it's like a split. It's really a split all across, 37% anterior and posterior, and no one would treat this in a cervical collar. So so the first 3 options is almost a 30% split, with most people favoring number 3, anterior and posterior. Would you address the adjacent segments at C3, 4, C5, 6, C6, 7, in addition to the C4, 5 injury? So we'll get a vote on that. All right, so 38% said they will treat strictly C3, 4. In addition to the original injury, 13% they would do C5, 6 only in addition to the injury. 0, no one would manage C6, 7 and the injury, and majority, 50% said they would address strictly C4, 5 injury. So between the C4, 5 injury and the level above, that's the highest percentage. So for this patient, because of the subluxation, especially because my plan was actually to manage this patient anteriorly if I could. So the plan, you take him to the OR and you see what you can get with reduction. So this shows you after I made the exposure and put in the marker within the disc space. But even if you ignore even the marker image, as you can see, just from, I use a Gardner, I use a halter traction for all my cervical cases. I don't use the Gardner well. So I use for the anterior cervical, I use a halter traction with about 10, 15 pounds of weight. Less on the pound, especially if there's a distracting injury or like instability, as Dr. Molinari said, you don't want to over distract this patient sometimes as you attempt to reduce them. So I think for this patient, the guy was a small guy, so I think I used about maybe 10 pounds. And even with the 10 pounds on it, the guy is sedated. You see he's almost reduced. Now, so markers right there, and my plan was to address him strictly anteriorly. And because I was addressing him strictly anterior, as you remember from his original film, he had the subluxation at the level above. So my suspicion was that he will likely, if I were to stop, if I were to stop at a C4 5, he will likely sublux at the level above because he already had the progressive subluxation. So the forces will likely lead to progressive kyphosis. So I did a 2-level ACDF on him, and we opted to stop with that. So here's his image 5 years post-op, and he still maintains some kyphosis at the top level. So we did the surgery, lordosis, but clearly from his adjacent segment disease, he's developed, so most of his kyphosis is coming from the lower levels. But he's completely asymptomatic, he's pain-free, he's back to driving his 18-wheeler and back to work, no ridiculous symptoms, no myelopathic symptoms, and he's had complete recovery or improvement of his of the ridiculous symptoms he had preoperatively. So any questions about that case? All right, we'll move on to the next case. This is 27-year-old male, MVC rollover, excuse me, going 55 miles per hour. So the patient just happened to be driving through Rochester, was visiting a friend, and they were actually heading back to Ohio. He self-extricated from the car, neck and right arm pain, so had some symptoms concerning for radiculopathy. Thoracic trauma with spinal cord. He reported a remote history of a spinal cord injury in the thoracic spine with complete recovery. So we really didn't know the extent of his original, of his chronic injury, which was not really significant with his current trauma. So physical exam overall was normal. Obviously, he reported subjective arm numbness, which you can only interpret as possible radiculopathy from his fracture. So on CAT scan, you see the axial view, the sagittal view, the coronal view. On the coronal, you see the fracture line right there on the right side. On the sagittal view, you have the inferior articular process of C4 is fractured. And as Dr. Molinari demonstrated, you have pretty much a loose, a floating lateral mass where you see the fracture right there through the lateral mass, through the pedicle, and you also have the laminar fracture right there. So this is just representative films. This right is actually not a fracture. What you see right on the coronal is just just a nutrient vessel. It was critically evaluated. So he has a C4 laminar fracture, right C4 lateral mass fracture, and pedicle fracture. Forgot to include that with a C4-5 anteriolisthesis. Anteriolisthesis is not you see there's some listhesis right there. And because of the symptoms he was reporting concerning for radiculopathy, that was when he had an MRI. And on the MRI, you can see there's actually disruption of the disc at that level. And if you think about the force, it's going 55 miles per hour. So the windshield was broken from head trauma into it. But he had, so you think about the forces. So even though he was able to get up and walk, and he still had, so this is an unstable injury with disruption of the discal ligamentous complex. Some stenosis there from the fracture is hard to tell because of some of the hematoma in that area. And this is just another view, and you see the disruption right here of disruption of the PLL right through there, which was really noticeable during surgery. So how would you manage this patient? Anteriorly, posteriorly, anterior and posterior, or would you just do treat this non-operatively in the collar? All right, so majority, 55% said they would manage the patient strictly anteriorly, 30% posteriorly, 15% anterior posterior, and no one would treat the patient in the cervical collar. So majority anterior, followed by posterior with 15% anterior posterior. So we performed, for this patient actually, we discussed because of the fracture at the level above, and sometimes there's concern that even though you manage, like Dr. Molinari mentioned, when you go posteriorly, sometimes you may need to do 3 levels in order to get like good fixation, especially in this case where the lateral mass is fractured. Now, one of the benefits here is unilateral. So at least there's still some, this is almost complete stability on the contralateral lateral mass on the left side. But with that lateral meniscus fracture on one side, then you have to be concerned sometimes that, since this is unstable, it may also lead to some instability at the level above because you're already fusing the level below. So, but in this case, I opted to, this was discussed with the patient. He, as most patients would tell you, they want you to do what you think is best for them. And, in my, this is a 27-year-old patient. Personally, if this was me, I think I'll go for a single level and take the risk of potentially developing subluxation at the level above, which may be asymptomatic. And so we decided to proceed with just a single level, understanding that there's a risk for him to develop instability at the level above. And unlike most single level ACDFs where you have the patient wear a soft collar and you take it off during their 2-week follow-up visit. For a patient like this, I told him because of the risk of progressive kyphosis, so we'll plan to almost treat him as if he, was still treating him non-op. So he was treated with an ACDF, placed him in a Miami J collar, and because he was driving through Rochester heading to Ohio, I contacted one of the local spine surgeons at the university, and she agreed to take over care. And I was able to transfer. I sent her the images, and she followed up. So I really haven't. This was done almost 2 years ago. So this is the last images from the OR that I have for the patient. All right, thank you. Any questions?
Thank you, Dr. Menga. Why don't we transition to Dr. Section's slide or talk, since we're running a little behind, and then let's address questions after his talk. He only has one case.
All right.
So.
Right. All right. Let's see. Okay. Is everyone able to see my screen?
Yes.
Okay. All right. Well, thank you all for being here. My name's Jarren Section. I'm the current spine surgery fellow here at URochester Strong Memorial. Got no disclosures. So this is my patient, 48-year-old female. She was involved in an MVC. Husband fell asleep at the wheel and veered off the road. Airbag did deploy. She actually self-extricated at the scene and was ambulatory. Taken initially to an outside facility by EMS and later transferred to Strong. So on admission, she endorsed neck and back pain, denied any radiating pain, weakness, numbness, tingling to her extremities. Didn't have any significant past medical or surgical history. This is her exam. So she was neuro intact as far as motor function. Additionally, sensation was intact bilaterally. She didn't have any signs consistent with upper motor neuron injury, and her rectal tone was intact. She had good volitional control. So this is her CT scan. On the left side, you can see she's got what looks concerning for bilateral facet dislocations, and then on the right, the sagittal. So this is a C6, C7 level injury. You can appreciate the anteriolisthesis of C6 on C7, widening at the spinous process, and some rotational component possibly as well. Okay, it's the right side. No appreciable fractures of the facets. Okay, an MRI we got pre-reduction. She did not have any major disc herniation or disc findings. She did have, of course, an injury there, and an injury to the posterior ligamentous complex is pretty apparent. Again, the right side of her injury, left. I'll also just mention she did have a L2 flexion distraction injury as well. This was ultimately managed operatively. I'm not going to further discuss it, only for relevance of the talk though. So initially in the ER, we placed her in Gardner-Willis tongs and traction. This is the 30 pounds of traction we initially had on her, and ultimately got up to 67 pounds. We were unable to attain the close reduction. Of course, it could have gone up on weight, but I'll go ahead and pose it to the crowd. What would you all have done for this patient? Is the poll up? Okay, thanks. All right, so it looks like 40% say anterior procedure, 35% say posterior, 20% say anterior and posterior, 1% or 5% say non-operative. So, you know, a lot of different ways to think about this as far as deciding what you're going to do. Again, this patient didn't have any facet fractures, no in-plate fractures. So, you know, anterior approach is, you know, it's an easy approach. It is something that could give you a pretty significant fixation because you're fixating into the vertebral bodies versus the facets. The question is, though, you know, we didn't have successful closed reduction. So you're relying on being able to get your reduction anteriorly. Of course, the bailout would be to go to posterior. Posteriorly, yes, you can get your reduction by means of using towel clamps on the spinous processes. There's also been there are other techniques as well, including fixation. Again, we are working at C6, C7 level. Some people are more hesitant to put fixation at C7, but you know, you can use your fixation to attain your reduction as well. Anteriorly and posteriorly, if it were a significant, you know, significantly unstable injury and with associated fractures, it's something you could consider. So it is something you definitely could consider. Non-operative management, you know, I think 77 to 80% has been quoted in recent literature as far as failure for non-op management. So this is what we elected to do. We did an anterior-based procedure. This is the initial x-ray while she was on the table. She's still in Gardner-Wells tongs and traction. We'd not attained the reduction yet at this point, but we localized here to the level. It's pretty easy to find that level due to the step off. Ultimately, we did a discectomy, and we used, but prior to the discectomy, used Caspar pins to attain our reduction, and we're successful in doing that. Again, you could have gone you could go posterior and do this as well, and I think it's a reasonable bailout. But since we were able to successfully do this, and given the fact that it was purely ligamentous or discal ligamentous, we elected for an ACDF procedure on this patient. This is our immediate final or our final imaging. Overall, she did well. She remained neuro intact. This is her 7 months post-op with maintained reduction. She's back to daily activities, normal daily activities, no restrictions. So I think overall, this was you know, a good option for this patient. Again, she didn't have any major fractures of the facets or end plates, and so I think using an anterior approach for this is a very reasonable option if you're able to get your closed reduction, or even if you're able to get intraoperative reduction using an anterior approach. It's something that you should be able to have in your tool bag, and actually worked out well in this patient's case. So, thank you.
So thanks, Jarren, for that nice overview. So there's two questions that came up earlier, and this is something we'll pose to the faculty. The one is, do you routinely obtain a CT angiogram or CTA prior to operating or reducing these patients? Dr. Molinari, what do you think?
So American College of Surgeons ATLS guidelines say for any cervical fracture dislocation, you should get a CT angiogram because there's a high incidence of vertebral artery injury. Now, they often do have vertebral artery injuries. It's often unilateral, and you wind up putting them on an aspirin. But I think the protocol in our hospital is to get a CTA if there's a fracture dislocation of the spine or there's a fracture that involves a neuroforamina. So at our facility, they will get the CT, they will get the CTA, and then you just take that information for what it's worth. And most times you wind up putting them on an aspirin.
So Dr. Menga, any thoughts?
No, I agree with everything Dr. Moller just mentioned. I think, yeah, you know, as he mentioned, most of the time it's unilateral, and a lot of times is and for a lot of these patients, it's asymptomatic. So that's why even, you know, there've been published articles. So if most of these patients are asymptomatic, hence why get CT angiogram? So that's also a debate as to why get the angiogram if it doesn't change how you manage these patients. But it does change how you manage them if you have to consider putting them on some anticoagulation. And we've had cases where neurosurgery, because of the degree of the dissection, is opted to take the patients to do proceed like a CT endoscopic procedure before we proceeded with the surgery because they felt it was pretty significant.
So I think the protocol here, if they do get the CTA, then you already have an answer. But there are situations where if they don't get the CTA, you want to get to the OR. If there's not a transverse foramen fracture, I think you can go ahead and do the procedure, but really on a case-by-case basis. The other question is, from a participant here, what recommendation do you make in terms of instrumentation and graft if you attempt an anterior approach and are unable to get an open reduction? So you're trying to go anteriorly, you're not able to reduce it. What kind of instrumentation are you going to leave, and then then try to go posteriorly, I guess?
So there've been descriptions of you do, in that case, you can do a discectomy and leave it open, and then you flip and you go posteriorly and do your reduction and instrumentation, and then you flip back anteriorly and you put in your interbody and plate if you chose to put in a plate, or you just put in the interbody. There's also a description of you do the reduction, you put in your cage, and you can put a plate, but have the plate only fixed at one level. So use a short plate, fix it at one level, flip the patient over, get your reduction, and then you go back and instrument. So it's almost like a buttress plate. So you make that decision whether or not you want to go in and put screws at the adjacent segment, or just leave the buttress plate, because that already stops the graft from extruding. I personally, I think the cases where I've had to do anterior posteriorly, I put in a cage. The reduction, I don't think the reduction that was necessary wasn't that significant to be concerned about putting in a cage and then struggling posteriorly, or you put in a cage and then when you flip posteriorly, the cage get extruded, and then you may end up with a cage impinging onto the retropharyngeal space. So I haven't had any of that. So I think Dr. Molinari would probably have an extensive experience to let us know if he's had any issues with maybe doing some instrumentation or interbody anteriorly before going posteriorly, if you have to go posterior to reduce.
No, Manny, I'll agree with you. I spoke before the two cases I had, and it's not like the thoracolumbar spine where it's a big production to go back anteriorly. It's pretty easy to go back at the third stage in the anterior procedure at the same setting. So you just pop the sutures and put your graft in. So I did exactly what you did. I went back after the posterior procedure and then just flipped them and did a quick anterior and put the graft back in. So on the two that I had, I did graft. I would argue that if you're going long posteriorly and you've done your discectomy in the front, you may not even have to put a graft in. It may just auto-fuse. So I think it's debatable whether you have to go back, but I'm telling you, it's pretty easy to do. And the two that I had was pretty easy. I just popped the sutures and you're right there. So I went back and put the graft in just like you said, Manny.
Okay, so there's another question asking, I find it hard to confirm that the C6-7 is reduced anteriorly, especially if, by looking in the wound. And is there any strategies you use? So I'll take this one because that was my case that was presented earlier. So I really depends on the neck, and if it's a tall neck, as that last patient was visualized easily, you can get a nice lateral C-arm image to show you whether or not those facets are lined up, especially when you have that reduction, the Gardner-Wells in place. I think you can actually see the facets a little better. Now, there are definitely cases where they have a large neck, you can't visualize it as well. Those are the scenarios where I actually bring in a flat plate and obtain a lateral X-ray, so it's a lot better than a C-arm. In these cases where I do a ACDF, I always get a CT that night of, so that way I guarantee that it's reduced. I can sleep better at night. And if for some reason, if it's perched, then I always kind of go back the next day and do a posterior approach. So we'll address this question, then I'll briefly discuss a case. It says, can you please review your awake close reduction technique? So I think Dr. Molinari has the most experience with it. Can you tell us your technique?
So two ways have evolved for me doing awake close reductions. When I first started out, I did the typical 10 pounds for the head. First of all, you have to get an X-ray first to make sure you don't have a non-contiguous injury, right? You also want to get an X-ray with your light weight on the head, 5 pounds or so, to make sure that you don't have a craniocervical injury, or you look at your CAT scan, okay? So you want to make sure you only have one injury to the spine and you're not missing an injury. When I first started out, I did 10 pounds for the head and then 5 pounds per level and added weight sequentially, taking X-rays at the bedside. Then I evolved into this water skiing technique where I would put the Gardner-Wells tongs on the head and have someone hold the feet and just use my hands to gradually pull traction. I like that that technique, you can gradually put additional force on the head, and you can feel the reduction very nicely with your hands on the Gardner-Wells tongue. So that's how I currently do it. I use what I call the water ski technique by just using my hands on the Gardner-Wells tongues with lateral x-ray at the bedside and pulling gradual weight. Now, one other point I would like to make, it is very, very easy to reduce bilateral facet dislocations. The ligaments are completely ruptured, so that's easy. The hard injury to reduce is the unilateral facet dislocation. Sometimes it requires a lot of force and a lot of weight.
Okay, so I'll briefly discuss my cases here. So for the sake of time, we'll try to go through these. This is a 52-year-old hearing impaired woman who fell down the stairs. On presentation, she has 5 out of 5 bilateral deltoids triceps. However, 4 out of 5 wrist flexion and wrist extension, and 1 out of 5 in her finger flexion and the hand intrinsics. Diminished rectal tone. So you can appreciate there's a subluxation of 6 on 7. She has a congenital autofusion, so clipophile congenital fusion there. So on the right side, she has a jump facet with a fracture. On the left side, she has a perched facet. On the MRI, you can appreciate the large disc herniation there at 6-7 with cord edema and extending up and down. And this is her axial image here. You can appreciate the large herniation. So I placed her in traction in the ED. And so the question for the audience is, would you manage this anteriorly, posteriorly, or front back? So about 44% are saying anterior, and about 56% are saying anterior posterior. So that's a reasonable distribution. Nobody said posterior only. So what I did for her is what I described earlier, which is I did the 1-level ACDF, got that disc out, and I CT'd her that night. And the other point that I want to bring up is, she came to the ED, or we got consulted at 4:20. So I made sure to get her in the OR as soon as I can with the logistics of making sure she's ready from the anesthesia standpoint. So we made an incision within about 4.5 to 5 hours. So on the imaging, you can see bilaterally she's reduced. However, because of her cord injury, I felt to give her the best chance, I also decompressed her posteriorly and took her from C5 to T1. So she unfortunately remained a C7 Asia B, and she actually passed away from a MI about 4 years post-op. So as far as this case, I don't think I would have done anything different. I try to, especially with the patients that have neurological injuries with the jump facets, I do try to go front back to decompress them as extensively as possible and give them the best chance possible. So the prevalence of clipophile syndrome in prior literature used to say about 1 in 40,000. We actually looked here in Rochester, patients coming through the ED. We actually found the prevalence in Western New York was about 0.58% or 1 in 172 patients. So it's not as rare as has been described. And as you can imagine, the lever arm there is acting like a prior fusion, so that they have a higher rate of either central cord or some type of facet injuries. So the next case is a 52-year-old male who struck a tree with his head. He was helmeted while bicycling. He came in with a 4+ out of 5 right tricep strand, diminished sensation in his index and middle finger. He's right-hand dominant. He works as a bank manager, and he's a very active individual. He got injured while biking. He also qualified for the Boston's marathon. So he's asking me, when can I go do my marathon? So on his imaging, there's a subtle anterolisthe of 6 on 7, but very, very subtle. You can appreciate on the sagittal cut the right C7 facet fracture. On the axial, you can appreciate a small fracture there in that C7 region. So this is what, from Dr. Molinari's talk, this is what would be considered an F1. So there's a good good option to either manage it non-operatively or operatively if depending on how worried that person is about his weakness. So again, this person is a marathon runner, very active. On the MRI is minimal herniations, no really pathology there. There is some neuroforaminal stenosis on that right side of 6-7. So how would you, let's go ahead and pull that poll up here. So the options are, would you do a 6-7 ACDF? What about going posteriorly, doing a foraminotomy, or doing a non-operative management with a collar? So about 45% said do a ACDF, 5% posterior with a foraminotomy, and about half of the people elected for non-operative management. So, I had a good discussion with this patient and explained to him, we could do an ACDF. There's a risk of adjacent segment disease. And in my practice, I try to, especially if there's a 4+ weakness where if they're going to be able to tolerate it, I try to manage them non-operatively. And that's what we did for him. Hard collar for 3 months. I saw him in the office monthly, gave him some gabapentin for his numbness. He's doing well 6 months post-op. He got out of his Boston's marathon and going to try to requalify again. So the nice study out of Pitt where they looked at 74 patients with unilateral cervical facet fractures. 7 out of these, or 9%, converted to surgical management because of radiculopathy or radiographic progression. But the majority of them were able to respond to non-operative management. So again, the key with these is follow them closely and individualize the care to the patient, because some people may not be able to tolerate it. This patient is bank person. He's not a construction worker, so his tolerance for it may be a little more than somebody who's doing a little more manual labor. So I'll finish up with this, and we can address some more questions here. So I'll go back to one of the questions we skipped earlier. This is a question to the faculties. Let's say you attempt a closed reduction and you're considering a non-operative management, and you're actually successful with your closed reduction. If there's any PLC signal on the MRI, would that affect your decision to leave them with non-operative management, or would you consider doing surgery? Dr. Menga, what do you think?
Yeah, I think it's a tough decision to make because sometimes the PLC edema doesn't necessarily mean injury to the PLC. It could be an edema and inflammation from the trauma, but not necessarily true disruption of the PLC. But yeah, if you're dealing with a case of if it's a bilateral, then it certainly is likely disrupted and injured. So in cases like that, yes, with reduction, I think I'll be more inclined to fix. Because of the disruption. So, but if say it's unilateral, and even say if it's on a CAT scan or it's like a unilateral perched facet, and you feel have some confidence that the contralateral side is stable, then maybe in certain patients may be able to take that risk to treat them non-operatively.
So just for Dr. Molinari and Dr. Menga, what are your thresholds to offer non-operative management for some of these fractures? Let's say they're having some numbness or some pain. Do you watch them for a month, let it declare itself, or how do you? What's your algorithm?
It depends on how severe. So similar to elective cases that we see in clinic, it depends on how the severity of the symptoms, and also the severity of the symptoms and the tolerance. And I think it's one of those where you have an face-to-face conversation with the patient and you discuss everything associated with non-operative management and surgical management. We know for radiculopathy in general, and for non-traumatic radiculopathy, we know 75% of patients are going to improve without any surgical intervention. So that's a conversation. I've actually had one of those recently, a few months ago, when the patient actually had a previous C5 radic, came in with a unilateral fracture and had recurrence of his radic with the fracture. And we discussed everything. He had taken medication before for his C5 radic, and the radiculopathy went away. So we discussed doing the exact same thing because I felt his fracture was unilateral and we could treat it without surgery. and his symptoms went away completely. And about 6 months, so this is like 3 months ago, about 2 months after he developed some symptoms, and we started him again on some NSAIDs, and his symptoms went away. So I think part of it is discussing, having that, conversation with the patient, and discussing your plan. Now, if there's weakness, then you have to be concerned. But as we know, sometimes even with weakness would improve with non-operative management. So I think it's one of those things you have a strong, good discussion with the patient, and you make a decision. So I think it's patient by patient.
Oh, so for me, it's age, neurologic status, and personality of the fracture. Younger age patients, pediatric patients, I'm more inclined to try to treat non-operative if I can. Neurologic status, if they're intact and the spine is aligned, I'll look at the personality of the fracture. If it's non-displaced, I may go with a halo. I have 2 or 3 cases of floating lateral masses that are non-displaced in younger patients that were neurologically intact that I successfully treated in a halo. I didn't do a 2-level fusion on them. Again, the personality of fracture, you're looking at the integrity of the hooks. These are fractures that involve the posterior restraining hooks of the spinal segment. So again, those fractures that are less than 40% of the hook, those fractures that are less than 1 centimeter, more inclined to be successful with treatment with non-operative management. Sometimes I'll stretch my indications, as I said, in the younger patients who are neurologically intact with minimally displaced fractures, even if they're greater than 1 centimeter. I'll go to a halo, I'll follow them to see if they develop a neurologic deficit or subluxation. If they do, it's usually early in the 1 to 2 week period, and they'll get an ACDF operation.
Right. Well, I'd like to thank all the faculty. We're I think right on time, a little bit over, but we appreciate the AO Spine and the fellowship committee for the opportunity to present this webinar. We'll try to do this again next year, and we'll wish you all a good night and good luck with the rest of your fellowship. Thank you.
All right. Thanks, everyone.
Good night, everybody.
Good night.